it was really good. I really enjoyed listening to that. Can you hear me?
Yes, I can hear you. Yes. Audience, can we all hear Diane?
Yes, we can.
Yes, we can.
Fantastic. Fantastic. Okay.
So thank you to Dr. Helen Garr for the presentation earlier, very informative. And again, it's just making sure that women have a basic understanding of what menopause is all about. So I'm Diane Porterfield Bourne. I'm a nurse practitioner. I live in Worcestershire and I specialise in menopause and HRT. I help support people in the workplace. I help run clinics, private clinics in the UK, and I advise people all about menopause and HRT within business and the NHS as well. So that's a little bit about me, and this is really what we're talking about menopause and about HRT. So today I'm going to be talking about the myths and the facts around HRT. So first of all, menopause. What is the menopause? Menopause really is a Greek word, meno meaning monthly and pause means to stop. The most common age that women experience the menopause really is in the mid-40s. This obviously varies. Some women, about 1 in 100 women, can have an early menopause, which is very important, and they need to make sure that they get really good intervention. So, but the most common age for women to go into a natural menopause is around the mid-40s. Different types of menopause. Like you've got the natural menopause, which is what we're really talking about today. This is what happens to every woman. We have a chemical menopause in which we have certain drugs that actually push us into an earlier menopause, or a surgical menopause, which is when we have surgery such as a hysterectomy, have our ovaries removed, that pushes us straight into the menopause as well. But ultimately, we start to develop the symptoms of menopause because the estrogen levels start to plummet. Menopause and the ovaries are there that contain eggs. We're born with a finite amount of eggs. And when those eggs start to dwindle down, our estrogen levels start to plummet, which of course is the ending of our fertility. As the estrogen starts to fall down, I like to use this term as estrogen deficiency. And we have short-term symptoms, which I call short-term symptoms, but probably most people would think it's actually lasts quite a long time. But the more short-term symptoms of estrogen deficiency are predominantly the hot flushes, the night sweats, anxiety, lack of confidence, dry, itchy skin, things like this. Whereas the long-term effects of estrogen, sorry, can you go back, Carla? Thank you. The long-term effects of estrogen deficiency are what I class as being the really important things, such as estrogen deficiency can drive increase our cardiovascular risks and the risks of osteoporosis. So those are the main two things there. Thank you, Carla. So what is hormone replacement therapy? Well, basically what it is, it's replacing like for like. You're replacing the hormones that your body is no longer producing. So the one thing I wanted to make sure that we make everybody aware is that younger women that go through the menopause, they can take either hormone replacement therapy or the combined pill. And all you're doing is replacing the hormones that your body's not producing anymore. So if you go into the menopause when you're in your early 40s, and the normal natural age of menopause is in the early 50s, if you don't have hormone replacement therapy or take something like the combined contraceptive pill, you're going to be deficient in those particular hormones for many, many years. Whereas somebody that goes into the natural menopause in their late 40s, early 50s will have been estrogenized far more than anybody else. So that's why it's really important to remember that younger women really need to have hormone replacement therapy, or certainly be looking at taking the combined contraceptive pill. The types of HRT that your GP prescribes, that I prescribe, that your that menopause specialists prescribe is what we call regulated bioidentical HRT. And this is really important to know. This is what's in the BNF, in the drug formularies that any health practitioner can prescribe to you. We have years and years of research to demonstrate its effectiveness, its safety, its efficacy. We know side effects, we know dosages. There's another type of hormone replacement therapy that's called unregulated compounded bioidentical HRT. And many or most of the leading menopause authorities do not advocate this type of HRT. The type of HRT that I do advocate and I prescribe, your GP prescribes, is the regulated. And this is as close to the body hormones as it possibly gets. And what we're doing is we're replacing those hormones we're now deficient in to improve our short-term symptoms, but ultimately improving our long-term health. Thank you, Carla. So the facts about hormone replacement therapy. It's a really complex subject because we have lots and lots of different perceptions about menopause and about HRT. Because many people think that it's just something that the menopause is just something that you need to grit your teeth and get on with. Some people think that they want to take any medication they can possibly have to improve their symptoms. Most people are just somewhere in between. But a lot of it's based on our culture, our own social beliefs, what our own mom went through, our own sisters went through, any family history that we have, and also what we find out in the media, what we read about, what we hear about, what people are gossiping about, scaremongering stories read on social media, etc. So we all have our own different perceptions about menopause, and certainly whether we are more inclined to take HRT or not. But what I want to say is that there are years and years of research to support the use of HRT for improving menopausal symptoms and improving long-term health. Because if we have estrogen and hormonal deficiencies for many years, it will have a very negative impact, particularly on our cardiovascular system, but also on our bones as well. And I think what's important to remember is that we need to be providing accurate advice. There's so much conflicting information about menopause and HRT. We need to make sure that whatever information we're giving to patients that we see and people that we're talking to, that it's accurate, it's up to date, evidence-based advice. And really, that's what, as health professionals, we have a duty of care to make sure we can do that. And obviously, we'll be discussing this a little bit later. And anybody that wants any information about this, please contact me. Now, there was an article that was published just literally a few weeks ago that I found was really interesting. It was produced by Sarah Hillman from Warwick University, and she was basically detailing the inequalities when it comes to HRT prescribing. It was noted that in areas of higher deprivation, that women were often either not prescribed HRT or prescribed types of HRT that probably wouldn't be recommended for their health conditions. And so therefore, we need to be thinking that we need to address these issues of inequality within certain areas and make sure that, oh, Carla, are you there?
Hello, sorry, did I go off altogether?
You did. I can't see you. Oh, I can't see my screen.
Sorry, let me go back into the screen. Can you see that again now?
Oh, there we go. Thank you. It's on now.
Lovely. Sorry, internet connections. Sorry about that, everybody.
That's all right. So yeah, there are lots of inequalities when it comes to HRT, either prescribing of it or prescribing the types of that maybe we shouldn't be prescribing to people. Now, what's really important about HRT is the type and the route of it. The best forms of HRT is when estrogen is absorbed through the skin in either a patch or a gel, and it's far safer. And what they did find with the inequalities with HRT prescribing was that most people were given the tablet version of HRT, in which has slightly increased risk factors, whereas when estrogen is absorbed through the skin, it has really good benefits for the cardiovascular system. So that's what's really important. The risks and the benefits. Now, this is something that people have to discuss in detail, and this is why menopause management needs to be very individualised, because what's right for one person may be not right for another. But on the whole, the benefits of taking HRT will outweigh any risk factors. There are very, very few risk factors when it comes to HRT, and they're actually there are lots of benefits to it. And the long-term benefits predominantly are the cardiovascular improvements, the prevention against osteoporosis, but and also things like vaginal atrophy. Women that suffer from frequent urinary tract infections, have painful sex, vaginal dryness or itch, or can't even have smears because they've got such bad vaginal dryness. We need to be thinking about making sure that these women are prescribed with a systemic HRT, or certainly look at giving them vaginal estrogen, either in creams or capsules, obviously for their health, and also, you know, really uncomfortable condition. So long-term benefits of HRT are really quite significant. Thank you, Carla. Okay. So many people think there are far more risks than there are benefits to HRT. So the one thing everybody says is that, oh, HRT will give me cancer, will give me breast cancer. So I just want to discuss just a couple of things really that I just want to highlight, which are really important. There's lots of conflict with different governing bodies when it comes to giving out information and interpretation of the research regarding sort of like HRT and breast cancer. However, there are some studies that are very, very clear now that there are no limits on the dose or duration of HRT. So one of the myths about HRT is the fact that it can only be given for so many number of years. Well, this isn't true. Basically, it's about risk versus benefit. So if the benefits of staying on HRT outweigh the risk factors, and you have no other underlying risk factors that the doctor's very concerned about, then potentially you could stay on HRT for many, many years. I know ladies in their 80s that are still taking HRT. So there's no limits on the dose or the duration. It's very individualized, and it's all about the benefits and the risk factors. If we're talking about breast cancer, there's always lots of hearsay and lots of gossip about it. There's always an awful lot publicised in the media about breast cancer risks as well. The latest evidence, again, controversial, but the basics is saying that there's a very small risk, increased risk of developing breast cancer when you take some kinds of HRT. Now, this is very small to virtually zero, but there is a very slight risk of developing breast cancer from taking HRT. But this is the most important thing, but not increased risk of mortality. So there's a slight increased risk of maybe getting breast cancer, but certainly not from dying from it. But most of this is related to the type of progesterone that's in the HRT. And that's what's really significant. This is why HRT really needs to be discussed for people that understand menopause and HRT. And it's then looking at risks and benefits, because the benefits of taking HRT really are the cardiovascular protection and also protecting our bones. But this isn't something that's often discussed. A lot of the myths and the gossip and the talk around HRT is often very negative, and it's always associated with the increased risks of it giving you breast cancer. Whereas I'm more pushing and explaining to people and raising awareness about the positive benefits of taking HRT, because we're far more likely to develop cardiovascular disease than we are breast cancer. And as you've already said, that although there might be a very slight risk of developing breast cancer for some groups of women on some types of HRT, we have a far greater risk of actually developing and dying from heart disease than we ever will with breast cancer. But it is an individual thing, and it's about discussing the risks and the benefits with each of those people. I often hear people say that I can't have HRT because I've got high blood pressure or I suffer with migraines. This simply isn't true. You can have HRT if you have high blood pressure and migraines. It's all about adequately managing your underlying problems. That's the reasons that you've got the high blood pressure. Getting yourself on some medication, making sure it's managed. But it is not a reason not to have HRT. And migraines as well. Many women say to me, I can't have them because I've either had blood clots in the past or I have migraines. And again, this simply isn't the case. The most important thing is that you put somebody on the right type of HRT, and it's the route and the type of HRT that's more important. So I've often changed people that have got migraines, certain types of migraines, and they're on oral HRT, and I swap them to the transdermal routes because it's far safer. But women really are going to continue to struggle because there is conflicting guidance from health professionals. And I think, particularly from a nursing perspective, we need to be educating our patients and giving them the best possible information and dispelling them any myths about HRT. Particularly about the duration. Many people think we can only take it for like a maximum of 5 years, and lots of GPs and health professionals wean their patients off it. And fundamentally, they don't need to. There's no reason for that. But again, it's about risk and benefit for each individual person. And as health professionals, we are educators, and we need to make sure that we're giving our patients the right information, accurate, up-to-date information, so that our patients can make informed choices. And that's all what it's about. I'm certainly not here saying that everybody has to take HRT, but it's really about understanding if it's something that you do want to take, you can take, and it's understanding what's right for you. Thank you, Carla. So I'm just going to go through the NICE guidelines. So these were published in November 2015, and every health professional, obviously, we have NICE guidelines for virtually every single condition or problem that we can face, and they're there as guidance. So really, that women under the age of 40 that develop menopausal symptoms, this is a group of women that need some very, very structured support and investigations, and to see if they have something called premature ovarian insufficiency. If they do, as I said earlier, it's incredibly important that these women get very good follow-up, and they need to be getting on either the combined pill, or they need to be taking hormone replacement therapy, because they're going to be estrogen deficient. And as we've said, you've got a huge risk of developing cardiovascular disease and osteoporosis by estrogen deficiency. So these groups of women need some serious management, and they need to be staying on HRT, ideally, or with a contraceptive pill up until the natural age of menopause, which will be 51. So that you're then supplementing their deficiency with HRT or the combined pill. Women, and I want to say about the premature ovarian insufficiency. There's a fantastic website called the Daisy Network that's very, very supportive of women with early menopause. Women under 45 years may benefit from blood tests. So NICE guidelines say that they may benefit from blood tests, but blood tests are a very small piece of a very large jigsaw puzzle. And if somebody comes back with, they've obviously got clear menopausal symptoms, but their blood test, their FSH levels are saying that it's normal, then many women think, well, my blood tests are normal, so I'm not in the menopause. I don't really base anything on the blood tests. I mainly judge it on like clinical presentation. What's the age of the lady I'm talking to? What symptoms have they got? I don't necessarily need a blood test to tell me that this person's developing menopausal symptoms, but they can be beneficial to make sure that there aren't any other health conditions being affected. So women over the age of 45, they do not need any blood tests to check for the FSH levels, because over the age of 45, the levels are going to be high anyway. So it really isn't worth doing these blood tests. And again, it's unnecessary investigations, and it's an expense to the health service, GP. It's an invasive investigation, and you don't need that done. It's based on symptoms of that patient. As I've said, menopause needs to be individualised. Can I have the next slide, please? Thank you. So the big question is that we know a little bit more about HRT, the myths and the facts. So what are we going to do now to support our patients? I think the first thing we need to do is make sure that if we or anybody that we know or care for is developing any menopausal symptoms, is to get in touch with their GP. And also health professionals that are specialising in menopause care and hormone replacement therapy. Because these groups of people, obviously, they specialise in this, and menopause is quite a complex subject. and it can take a while to actually be able to discuss this with people and discuss their lifestyle, discuss the risks and benefits. But women need to be talking to their family and friends. It's really important that they start to open up and they start to talk about how they're feeling. They need to open up to partners, colleagues at work, and let people aware of how they're actually feeling. Think about, we need to be looking at evidence-based menopause information, because there's lots of information out there, but make sure that it is a robust, research-based, really good studies, you know, your gold standard research studies, because as we know, as health professionals, you can read anything into research and you can you know, pull out information to suit any different need. But it's looking at things like the British Menopause Society, the NHS websites, and things like this, to actually make sure that we're referring to the latest best practice information, and obviously the NICE guidelines too. And if people in the workplace have symptoms of menopause, then obviously we need to be thinking about how it's impacting on the workplace, how it's impacting on their ability to work. If they're having frequent urinary tract infections, or they've got a weak bladder due to estrogen deficiency, then, you know, they need frequent toilet breaks. Is this impacting on their ability to do their job? Have they got brain fog, which is a very common symptom of estrogen deficiency? You know, are they, is their work suffering? Are they on performance reviews because of the lack of estrogen affecting their memory? So it's very multifactorial, and its employers need to be aware how menopause can impact upon women's health as well. And it's, again, speaking to your employer and HR to see if there are any menopause policies in the workplace. And what really our job is here today, and as health professionals, is about improving awareness through education, research, but it's about removing the stigmas and the taboos. That's why events like this around building up to World Menopause Day, it's about talking about menopause. It's about not hiding away from it. It's actually like addressing the subjects and highlighting it, because the more women shy away from the subject and don't talk about it, nothing will ever change. And it's something that all women experience. So we have a right to feel better, and whatever decisions that we make are for ourselves and our families. So where can we seek advice? The British Menopause Society, so there's a good website there. We can find information, and also the Women's Health Forum associated with the British Menopause Society. That's a really good place to get information from. But if anybody would like to email me at inquiries@borntocare.co.uk, I can provide them with information as well. So thank you very much, Carla. I'm sorry I wasn't able to manage my slides myself, but I'll pass it back over to you. Thank you very much indeed.
Lovely. Thank you, Diane. Thank you very much. And don't worry about the slides. It seems that Teams isn't the friendliest, is it, for sharing documents? No. But I hope for everybody who's joined us, that was a useful session on HRT, and certainly following the advice from Dr. Helen Garr in session 1. And as we said, that we will be sending all of these recordings to you and all of these slides to you. I will continually put my email address in the chat box so that you can request those, because obviously there's a lot joining these webinars, and I'm not in the best world, and I don't have brain fog yet, but capturing everybody's name is going to be difficult in one session.